I think there are 15 participants. Okay. Thank you very much, sir, for giving us this opportunity. On behalf of Concord Biotech, I welcome all the delegates and faculty members. Sir, just a little bit brief about our Concord Biotech. It's a global biotechnology and immunosuppressant experts organization. We are basically into API and manufacturing. Started way behind 2000 by our founder, Mr. Sudhir Vaidya. We are into API and bulk drug manufacturer. We have the recently opened Asia's second largest plant in Limbasi, Ahmedabad, which is a state-of-art manufacturing facility having a US FDA, EU GMP, PMDA Japan. These are the several accreditations to be named for API facility. Sir, on behalf of our organization, I'm very much thankful and grateful to all to be a part of this webinar and looking forward for a way ahead. Thank you very much. I conclude my opening message. Please proceed.
Thank you, Mr. Sachin Palkar. So good evening to all of you, and good morning and good afternoon to all other people who are from the rest of the world. Today, our guest speaker for the day is Dr. Aishwarya Ravindran from Birmingham, USA. She's going to lecture us on histiocytic neoplasms from behind the scope, a primer on diagnosing different subtypes. This webinar is brought to you by Mumbai Hematology Group, supported by Concord Biotech, Biotech for Mankind, and managed by Perfect Square. I thank Mr. Abhishek Gupta and Team Concord, Mr. Yash, Mr. Kalpesh, and the Team Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker for the day, Dr. Aishwarya Ravindran from Birmingham, USA. All our discussants who are themselves eminent hematologists or medical oncologists, and you participants for sparing your Saturday evening, morning, and afternoon. Do not forget to visit our website, www.mhgindia.com, where you can access all our future activities and as well as past webinars. Next, that is tomorrow, Sunday, on 19th of February, 2023 at 11:30 a.m., we have an excellent webinar on modern antibacterial drugs in neutropenic patients by Dr. Aisha Jamshed Sunawala from PD Hinduja Hospital, Mahim, Mumbai. Now it's a time to introduce all our discussions for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Akshaya Mandloy Goel from Varanasi, Dr. Ankur Ahuja from Army Hospital, RNR, New Delhi, Dr. Debaditra Ray from PJ Chandigarh, Dr. Jaspita Das from All India Institute of Medical Sciences, New Delhi, Dr. Jyoti Bajar Sawhney from Gujarat Cancer and Research Institute, Ahmedabad, Dr. Kunal Goel from Tata Memorial Hospital, Varanasi, Dr. Manjit Mehta from KD Ambani Hospital, Andheri, Mumbai, Dr. Pulkit Rastogi from PGI Chandigarh, Colonel Dr. S. Venkateshan from Armed Force Medical College, Pune, Dr. Shashi Bansal from Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur, Dr. Tanuja Sheth from Tata Memorial Hospital, Parel, Mumbai, Dr. Udyan Khachi from Vadodara, Gujarat, Dr. Vidisha Mahajan from PD Hinduja Hospital and Medical Research Center, Mumbai. Now it's a time to introduce our guest speaker for the day, Dr. Aishwarya Ravindran from Birmingham, USA. Dr. Aishwarya Ravindran is Assistant Professor of Pathology at the University of Alabama at Birmingham, USA. She pursued her medical training at Stanley Medical College, Chennai, India. After her graduation in 2013, she pursued clinical rotations in United States, and subsequently in 2015, she joined as a research fellow in hematology at Mayo Clinic, Rochester, Minnesota. It was during this time she developed a special interest in histiocytic neoplasms, where she encountered a patient with Rosai-Dorfman disease. The novelty of this diagnosis triggered her patient to expand her research on these diseases during her pathology residency and hematopathology fellowship training at the Mayo Clinic from 2017 to 2022. It's my privilege to invite her to deliver a lecture on histiocytic neoplasms from behind the scope, a primer on diagnosing different subtypes. Over to you, ma'am, for your lecture.
Thank you for the kind introduction, and thank you, Mumbai Hematology Group, for the opportunity to present this webinar today. Going to share my screen. Yeah, I've developed a special interest in diagnosing histiocytosis over the years. And today, the main focus of this webinar is going to be how we diagnose these cases in real time and what are some of the practical challenges we face in diagnosing these entities. I have no disclosures. The primary learning objectives for today's presentation will be number one is to describe the classification of histiocytic neoplasms. Number two is to differentiate the clinical pathologic features with a special emphasis on Langan cell histiocytosis, Erdheim-Chester disease, and Rosai-Dorfman disease. And number three is to detail an algorithmic approach to work up for a histopathologic diagnosis. So the outline will be, I'll be starting out with the classification of histiocytic neoplasms, followed by clinical pathologic features, and presenting three cases, which are real cases I've seen through my practice, and finally concluding the webinar with an algorithmic approach to working up for a histopathologic diagnosis. Starting with an introduction to these histiocytic disorders, they are derived from the mononuclear phagocyte system, which is composed of monocytes, macrophages, as well as dendritic cells. There are a heterogeneous group of disorders with over 30 different subtypes. Not all of them are neoplastic entities. The word histiocyte itself can apply to both macrophages as well as dendritic cells. And depending upon the extent of organ involvement, they can have variable disease outcomes. Now, going into insights on the ontogeny of this mononuclear phagocytic system, from the time of birth, the bone marrow is the site of hematopoiesis, and the hematopoietic stem cells gives rise to the monocytic progenitors and the dendritic cell precursors. The monocytic progenitors gives rise to monocytes. Monocytes differentiate into macrophages. Similarly, the dendritic cell precursors give rise to the conventional dendritic cells as well as the plasmacytoid dendritic cells. Now, all of these cells are part of our immune system, so their role is to protect us. So what a fascinating physiology is that the resident macrophages, say the Kupffer cells in the liver, the microglia in the brain parenchyma, and even the epidermal Langerhans cells originate from the embryonic precursors, the yolk sac and the fetal liver, and they continue to be bone marrow independent throughout the adult life with a capacity to self-renew at a steady state. In setting of inflammatory conditions, the bone marrow can differentiate into the monocytes that can have the capacity to differentiate into Langerhans-like cells, as well as the dendritic cells has also the potential to differentiate into Langerhans-like cells. And that happens not always, only in the setting of excessive stress or inflammatory conditions and so forth. Now, talking about the neoplastic counterparts. So when there is a genetic hit, depending upon the pathway where this genetic mutation occurs, it can give rise to neoplastic entities. So the ones in red will be focus of today's webinar. The histiocytic macrophage neoplasm arise from the macrophage, and the dendritic cell neoplasms are those that arise from the conventional dendritic cells. There are also plasmacytoid dendritic cell neoplasms that arise from PDCs, but that will not be the focus of today's presentation. And also acute monocytic leukemia is the one that arises from the monocyte. Now, talking about genetic hit. So what is causing that genetic mutations in these diseases? Over several years, there have been like multiple studies showing the involvement of MAPK pathway mutations underlying the evolution of several of these histiocytic neoplasms. Another pathway that's involved is PI3K-AKT pathway. In a vast majority of histiocytosis, both Langerhans cell histiocytosis as well as non-Langerhans cell histiocytosis, the most common mutation is BRAF V600E. Now, I have to point out the exception is Rosai-Dorfman disease because this mutation is extremely rare in Rosai-Dorfman disease. Now, this BRAF is closely followed by the MAP2K1 genetic mutation, which codes for the MEK1 protein. And the other mutations include the RAS pathway mutations, which is more common in Rosai-Dorfman disease, specifically the KRAS genetic mutation. Coming to the PI3K-AKT pathway, that is more common in Erdheim-Chester disease compared to LCH, Rosai-Dorfman disease, and other histiocytic neoplasm. Now, why it is important to know about these genetic mutations? That's because there is availability of targeted therapy. For example, vemurafenib can be used in patients with BRAF mutated histiocytosis, and cobimetinib and other MEK inhibitors can be used in patients who harbor the MAP2K1 mutation. From a pathologist perspective, we have immunostains for phosphorylated ERK and phosphorylated AKT. They can be used as surrogates to understand if there is activation of either the MAPK pathway or the PI3K pathway. Although they are surrogate markers, confirmatory studies by next generation sequencing is recommended. So going into the classification of histiocytic and dendritic cell neoplasm, starting with the World Health Organization 4th edition, there are about 10 different entities of histiocytic neoplasms. Now, the recent classification, the international consensus classification in 2022, is predominantly similar in par with the WHO 4th edition. In addition, there are two distinct entities, the Rosai-Dorfman disease and ALK-positive histiocytosis, that were recognized as distinct histiocytic neoplasms, which also was recognized by the World Health Organization 5th edition as two distinct histiocyte macrophage neoplasms. In addition, the World Health Organization 5th edition also puts this plasmacytoid dendritic cell neoplasm category under the banner of histiocytic dendritic cell neoplasms, whereas in the WHO 4th edition, it was considered to be a distinct category under the realm of myeloid neoplasia. Now, talking about these entities that are highlighted in yellow, the follicular dendritic cell sarcoma, fibroblastic reticular cell tumor, or now it's called fibroblastic reticular cell sarcoma, they have quite different ontogeny compared to the other histiocytic macrophage neoplasm. They tend to evolve from mesenchymal stem cells. So the WHO 5th edition has moved these three entities into stromal lesions, and hence that will not be discussed today during the course of this webinar. So given that there is a lot of subtypes in histiocytic disorders, the 2016 Histiocyte Society classification has classified these diseases into 5 different groups. Now, again, not all of them are malignant or even neoplastic. Now, talking about the L group, L as in Langan cell histiocytosis also includes indeterminate cell histiocytosis, Erdheim-Chester disease, and mixed histiocytosis. C group stands for the C as in cutaneous lesions, but predominantly includes non-Langerhans cell cutaneous lesions, such as xanthogranulomatous lesions. R as in Rosai-Dorfman disease. M as in malignant histiocytosis. Now, the word malignant here refers to the overtly pleomorphic cytology of these tumor cells in this group. H group refers to hemophagocytic lymphohistiocytosis. Now, the focus of today's presentation would be primarily on the L and the R group entities with a brief overview of M group. And I'm going to touch base on M group as I go through each of these entities in the L and the R groups. It's just that there are phenotypic overlap between L and R group that corresponds to the M group. Now, starting out with Langan cell histiocytosis, morphologically, these cells have this nice grooved nuclei with moderate to abundant eosinophilic cytoplasm. I consider this nuclei to represent a coffee bean. If you're a coffee lover like me, then you can relate it very well to this picture here. And they're often associated with a lot of eosinophils in the background. They're not necessary for a diagnosis. The eosinophils are not necessary for a diagnosis of LCH. They're just that they form a part of the inflammatory stroma. So by immunophenotyping, these Langan cells are positive for CD68, which is a macrophage marker. And sometimes these cells show Golgi or a dot-like staining in the Langan cells. Now, majority of LCH cases are usually negative for CD163. A minor subset is usually positive. So CD163 being a more specific macrophage marker should not lead you away from a diagnosis of LCH when it's negative, because it's usually negative in LCH and also in other histiocytic and macrophage neoplasms. And some staining in the background are usually the admix reactive macrophages that is picking up the stain. And Langan cells are defined by the expression of both CD1A and Langerin. Historically, the presence of Burbeck granules by electron microscopy used to be the diagnostic phenomenon for this entity. But given that Langan is a surrogate for identifying these Burbeck granules and the ease of access of immunostains, electron microscopy is no longer pursued these days for diagnosing these entities. Now, the cyclin D1 marker, it's the overexpression of cyclin D1 in Langan cells and as well as other histiocytic neoplasms might have several different pathways, but in the context of histiocytosis, the most common pathway is the overactivation of MAP kinase pathway, and cyclin D1 is downstream of MAPK, so it's expressed in this neoplastic histiocytic cells. It has both nuclear staining and a weak cytoplasmic blush. BRAF V600E is positive in over 50 to 60% of LCH cases and is characterized by the cytoplasmic granular staining. So going into the clinical and radiologic features of LCH, it affects both children as well as adults. The most common site in children involve the bones presenting as lytic lesions. In the adults, the most common site is it's the lungs presenting as bilateral upper lobe predominant nodules frequently associated with smoking. The other sites of involvement involve the endocrine system, specifically the pituitary stalk. When affected, it results in diabetes insipidus for several years before this disease gets diagnosed. The other sites of involvement, although rare, they are not totally unheard of. That involves the lymph node, the central nervous system, as well as cutaneous manifestations. Now, in terms of cutaneous manifestations, there is a differential of a plethora of reactive conditions as well. There is no pathognomic skin features that would point towards a diagnosis of LCH. So it's primarily by skin biopsy and morphologic and immunophenotypic features. And also in the central nervous system, a subset of cases might develop neurodegenerative manifestations. Now, talking about reactive proliferations mimicking Langan cell histiocytosis. On this side, this part A, you can see a portion of a lymph node with a paracortical expansion of CD1A and Langan positive Langan cells. Now, this entity right here could be totally misdiagnosed as Langan cell histiocytosis just because of this innumerous CD1A and Langan positivity. However, compared to this part B of this figure, there is a sinusoidal distribution of CD1A and Langan positive cells. So the key distinction of Langan cell histiocytosis from the reactive process, the dermatopathic lymphadenopathy, is the pattern of distribution. LCH is a sinusoidal based process in the lymph node, whereas dermatopathic lymphadenopathy refers to the paracortical expansion of the Langan cell as well as dendritic cell. Another subtle morphologic clue is that these Langan cells are in a pattern similar to the CD3 positive T cells in the paracortex. That should also lead you towards a diagnosis of a reactive dermatopathic changes rather than an LCH process. A drop of wisdom coming from a hematopathologist perspective. LCH harbors the BRAF V600E mutation in over 50-60% of the cases. So when you are dealing with organs which have the cilia, especially the lungs with bronchial epithelial cells, or even this brain parenchyma, the ependymal cell lining, the cilia tends to cross-react with the BRAF V600E protein that is related to the axonal dinins in cilia that pick up the VE1 antibody. So caution is should be exercised when you interpret this BRAF staining in ciliated organs, and the positivity should be only attributed if you can see this in the Langan cells. Now, comparing the Langan cell histiocytosis morphology with Langan cell sarcoma, now LCS is a part of malignant histiocytosis and is characterized by this overtly malignant pleomorphic nucleated cells. Phenotypically, they are similar to LCH, CD1A, and Langan positive, but the key differential is based on your hematoxylin and eosin stained sections. The Langan Cells sarcoma, the word sarcoma could be misleading to leading us to think about other soft tissue sarcomas, but no, it's just like these are hematopoietic entities, and we should be treated like any other, like other hematopoietic histiocytic neoplasms, and they also tend to harbor MAP kinase pathway mutations. Now, going into the second category in the L group, the indeterminate cell histiocytosis. Now, these are just like similar to LCH. So you can consider them like a twin of Langan cell histiocytosis. You can see the same coffee bean nuclei and the morphology, but the difference is in immunophenotypic studies where it's CD1A positive but Langan negative. Essentially, by electron microscopy, these cases will not have the Burbeck granules that is seen in Langan cell histiocytosis. In terms of clinical presentation, it has predominantly cutaneous involvement and also harbors the MAP kinase pathway mutation. And recent studies have shown this recurrent ETV6 NCOA2 fusions. And there are more studies needed to ensure what is the long-term clinical outcomes for indeterminate cell histiocytosis as compared to LCH. So compare the indeterminate cell histiocytosis morphology to indeterminate cell sarcoma. Now, the key difference again for this comes under the light microscopy difference in the morphologic features characterized by this overtly pleomorphic malignant nuclear features of these cells. Phenotypically, they're going to be similar to indeterminate cell histiocytosis, positive for CD1A, negative for Langan. Beta V600, these also tend to harbor MAP kinase pathway mutation, just similar to Langan cell sarcoma. Now, there is an entity called interdigitating dendritic cell sarcoma. My goal is to just bring you awareness that these entities exist. So when you're facing with a differential of polydifferentiated carcinoma and undifferentiated sarcoma, or even a melanoma, you have to consider these histiocytic entities that could have phenotypic overlap, especially with melanocytic lesions. And it's important to phenotype them and identify the appropriate lineage so they can be treated appropriately. So this interdigitating dendritic cell sarcoma, it's positive for macrophage marker, that is the CD68, and is notoriously uniformly positive for S100. Now, if you do only S100 in such cases, one would think if this is a melanoma, especially characterized by the spindle cells, your first thought would be, could this be a spindle cell melanoma? But no, if you add a CD68 and if it is positive, and there are also other macrophage markers that can be picked up by this interdigitating dendritic cell sarcomas, and that should lead you to think this is a histiocytic lineage and not any other non-hematopoietic lineage. Now, interdigitating dendritic cell sarcomas are always negative for CD1A and Langan. Now, coming to the third entity, diagnosing Erdheim-Chester disease. Among all the other histiocytic neoplasms, this is one of the most complex diagnoses to make from pathologist perspective, because this is one diagnosis where there are no pathognomic features on histopathology to diagnose this entity. It requires correlation of clinical features, radiologic findings, as well as histopathologic features for a definite diagnosis. Now, the key radiologic features here is this bilateral osteosclerotic bone lesions involving the knee bones, and is present in over 95% of the cases, and majority of them present with bone pain in the bilateral knees, and their first consult is going to be a rheumatologist consult. So it's important to be aware of this ECD in the differential when evaluating these patients. Now, the other radiological classic findings in Erdheim-Chester disease are the hairy kidneys. This is nothing but the bilateral perinephric soft tissue infiltration. Those soft tissue infiltration are essentially this neoplastic histiocytes, and they produce a hair-on kidney appearance termed as the hairy kidney. The right atrial mass is also present in 40 to 70% of ECD cases. Coated aorta refers to the peri-aortic sheathing by this neoplastic histiocytes forming a peri-aortic soft tissue mass. Pituitary lesions can result in diabetes insipidus, just similar to Langan cell histiocytosis, and as well as there are cerebellar lesions, and if affected, can result in neurodegenerative symptoms in a vast majority of patients. Histopathologically, they're characterized by this infiltration of foamy histiocytes that are positive for macrophage markers, that is CD68. They're uniformly positive for factor 13A. This is a marker of fibrohistiocytic proliferations. Again, you can have this factor 13A expression in both reactive proliferations as well as in histiocytic neoplasms. Now, BRAF V600 is similar to LCH, is positive in about 50 to 60% cases of ECD. When you have BRAF V600 on morphology and you have other clinical and radiological features, that should be an easy way to diagnose ECD. But in the challenge comes in there's 30 to 40% of the cases that BRAF V600 negative, and that raises the challenge on histopathology that it could still represent reactive histiocytic proliferation, which is Erdheim-Chester disease, in which case NGS would be very helpful in conjunction with the radiological features to consider a diagnosis of Erdheim-Chester disease. Now, cyclin D1, just similar to LCH, is also uniformly expressed in ECD cases. And this relates to the overactivation of the MAP kinase pathway. And as you can see here, it's uniformly positive in the lesional histiocytes, strong nuclear expression, some weak cytoplasmic blush. Typically, you don't see this pattern of staining in reactive histiocytic proliferation. Reactive histiocytes tends to have variable cyclin D1 staining, and this uniform nuclear expression is very unique to these histiocytic group of neoplasms. Now, going to an overview of the clinical and radiological features of ECD, just like we discussed, the most common sites of involvement is this bilateral bony osteosclerosis around the knee bones, followed by the retroperitoneal lesion manifesting as hairy kidney, cardiovascular involvement, including the coated aorta. There can be endocrine manifestations, just similar to LCH, manifesting as diabetes insipidus. But compared to LCH, the nervous system involvement is fairly more common in about 40% of the cases, and a subset can present with neurodegenerative symptoms, especially if there are other brain parenchymal and cerebellar lesions. The other sites of involvement, like orbits and cutaneous sites, can occur in 1/3 of cases. The testis involvement, although is very rare and less than 5% of cases, in our observation, based on our institutional series, we have seen it often overlap with Rosay-Dorfman disease, and it can present as a mixed histiocytosis, ECD plus Rosay-Dorfman disease. Now, talking about a case of ECD mimicking reactive proliferations, this was a patient, elderly male, presenting with a vague abdominal pain, and CT abdomen showed some like retroperitoneal fibrosis that was biopsied. So this biopsy shows a marked fibrohistiocytic proliferation and also like abundant amount of plasma cells. The initial thought was this could be IgG4 disease because there was focal increase in IgG4 positive plasma cells, and bordering it was not exactly IgG4 IgG ratio was not over 40%, but they were suspicious for IgG4 disease just based on this. Subsequently, the patient presented a rheumatology with bilateral knee pain, and a whole body PET CT revealed the bilateral osteosclerotic lesion in addition to perinephric soft tissue stranding. Just based on these two pathognomic signs in radiology imaging studies, was highly suspicious for histiocytic neoplasm. So this case was reviewed as part of our histiocytosis working group consensus meeting, and additional stains were performed to further characterize this entity. And surprisingly, these histiocytes, which were thought to be just bland reactive histiocytes, were uniformly positive for BRAF V600E, as indicated by this nice cytoplasmic granular staining. And they were strongly positive for factor 13A, and CD163 just highlights this macrophage phenotype. This case emphasizes that ECD can mimic a plethora of reactive proliferations, and the key is a multidisciplinary approach and clinical pathologic as well as radiologic correlation. Now, in this case, next generation sequencing also confirmed the presence of BRAF V600E mutation. Now, talking about on the flip side, this was another patient who presented with bilateral proptosis, retroorbital pressure, and pain. MRI of the orbit showed an infiltrative orbital masses. It was predominantly localized on the superior and lateral part of the extraocular muscles. There was pairing of the orbital tendons. Initially, the histology showed like infiltration by foamy histiocytes with two-tone giant cells. Now, two-tone means this horseshoe-shaped nuclei in a giant cell that is called as two-tone giant cells. It is not pathognomic for ECD, but it's most frequently associated in ECD lesions, can be present in other xanthogranulomatous as well as reactive proliferations. Now, this by histology was CD163 positive, just based on histopathology and the MRI showing orbital infiltration. It was suggestive of Erdheim-Chester disease initially. NGS was attempted, but it failed due to inadequate tissue. The patient was started on interferon alpha, which is one of the monotherapies for Erdheim-Chester disease. However, in spite of treating this patient for ECD, she continued to have progressive symptoms. So the case was re-reviewed as part of our consensus group meeting, and the histology and the radiology were re-reviewed. So the radiologist pointed out, based on the PET-CT findings, the patient did not have any other systemic radiological features suggestive of Erdheim-Chester disease, such as the bilateral osteosclerotic bone lesions, hairy kidney, or cardiovascular involvement. Further, this MRI findings of this lateral and superior extraocular muscle involvement with sparing of the orbital tendons is more suggestive radiologically of IgG4 disease and not of ECD. ECD tends to be more intraconal orbital masses. So subsequently, an IgG4 stain and IgG was done, which showed an increased amount of IgG4 positive plasma cells here, over 100 per high power field, and the ratio was greater than 40%. Histopathologically highly suggestive of or diagnostic of even IgG4 related disease. And however, storiform fibrosis and other features of obliterative phlebitis were not seen on this biopsy, but this patient was treated like an IgG4 related disease, given Rituxan, and at 3 months, you can see this remarkable radiological response on this lateral and superior extraocular muscles. So this was a case of IgG4 mimicking Erdheim-Chester disease. Now, going out to our Rosay-Dorfman disease, morphologically, they are characterized by this round to oval nuclei with this small distinct nucleoli with frequent engulfment of these mononuclear inflammatory cells. Most often is lymphocytes, plasma cells, and occasionally can be neutrophils. And this phenomenon is called emperipolesis. Emperipolesis and this morphology has been historically regarded as one of the key features of Rosay-Dorfman disease. But I want to point out emperipolesis is not pathognomic for Rosay-Dorfman disease. It can be present in other histiocytic neoplasms, as well as it can be present in reactive histiocytosis. Now, these by morphology are positive for CD163 as well as CD68, which both of them are macrophage markers, and they're uniformly positive by S100, which neatly highlights this emperipolesis phenomenon. Recently, we described this marker called OCT2. It's a unique monocyte macrophage marker expressed by the cells of Rosay-Dorfman disease, but this OCT2 expression is absent in Erdheim-Chester disease and a vast majority of Langan cell histiocytosis. Now, cyclin D1, similar to ECD and LCH, can be uniformly expressed in RDD cells. Again, this suggests MAP kinase pathway activation, as cyclin D1 is downstream of that MAP kinase pathway. Now, talking about CD163 being a more specific macrophage marker, it can be negative in Rosay-Dorfman disease in approximately 10% of the cases, as well as CD163, like I showed another case of interdigitating dendritic cell sarcoma, can be negative in other histiocytic neoplasms as well. So that is what is more essential to do a panel of markers, such as other macrophage markers include CD68, CD14, or even CD4. CD4 I don't routinely use in my practice. That also highlights the background T cells. So in this case, coming back, although it was CD163 negative, a panel of immunostain markers, including S100, OCT2, CD68 not shown here, was positive, clinching the diagnosis of Rosay-Dorfman disease. Coming to the clinical and radiological features of RDD, it can have nodal as well as extranodal sites of involvement, and extranodal has been fairly common in the most recent years of our knowledge evolving in this disease group. The most common extranodal site is the cutaneous lesions, but can also involve other lesions such as the lungs, orbits, nervous system, and the bones, and as well as retroperitoneum. It's rare, but it's also one to be kept in the differential diagnosis when evaluating for histiocytosis in the retroperitoneal area, especially. The nervous system, RDD, is notorious to mimic meningiomas. So, although the radiology can suggest meningiomas, if histopathology does not show any features of meningiomas, think about evaluation for Rosay-Dorfman disease in conjunction with other differential diagnosis by doing a panel of immunostains. Now, the other associated conditions with Rosay-Dorfman disease include lymphomas as well as autoimmune conditions such as systemic lupus erythematosus, and as well as IgG4 disease can be related to us in a subset of Rosay-Dorfman disease. Familial RDD is extremely rare. I've not seen a case as of yet. But if there is a suspicion for an inherited form of Rosay-Dorfman disease, germline testing for this mutation can be considered. Now, Rosay-Dorfman disease, we know this nice histopathology that we just discussed now. But when it presents in sites such as the bones, it often presents as lytic lesions, and the morphology is not really characteristic. It doesn't really bring out those cells with emperipolesis distinctly. So this was a case that exemplifies the different phases of Rosay-Dorfman disease manifestation. This is RDD presenting as a lytic lesion of the femur. All you can see is marrowfibrosis. There is not any cells that distinctly pop out. And this was another case of Rosay-Dorfman disease in a patient diagnosed with RDD on a nodal site, was involving the bone marrow, characterized by this diffuse marrow interstitial proliferation or by these histiocytes. But it's impossible to characterize them just based on morphology on H&E sections. So an immunostains panel showed distinctly the CD163 positive histiocytes being strongly positive for cyclin D1, S100 being slightly weaker on the weaker aspect, but again, this could be related to the decalcification aspect, so they have to be interpreted with caution. OCT2 nicely highlights this Rosay-Dorfman disease cells, thereby sealing the diagnosis of RDD in these cases. Now, OCT2 can also functions as a B cell transcription factor and can be positive in the small B cells as well as plasma cells. So the small cells in your background are actually your B cells or plasma cells. So they serve as your internal control to analyze the positive staining in your RDD cells. RDD cells are really larger as compared to the small B cells in this background. Now, talking about BRAF V670 positive RDD, as I said, it's an extremely rare phenomenon for RDD to be BRAF positive. There are two reports in literature. One of them was an isolated RDD, the other one being a mixed histiocytosis, RDD plus Erdheim-Chester disease. Now, this case is something that I saw during my fellowship. It was a patient and middle-aged female with right inguinal lymphadenopathy, presenting with the involvement of the node by this RDD lesional cells picked up by positive staining for CD163, uniformly positive for cyclin D1, S100, even OCT2. And BRAF V600 surprisingly was also positive in these cells. Now, the question always comes, is it true positive or is it false positive? Now, BRAF V stain is a highly sensitive as well as a highly specific stain, but there are rare instances of necessary to rule out a mixed histiocytosis, especially an overlap of Rosay-Dorfman disease with ECD or Rosay-Dorfman disease with LCH by doing a whole body PET CT to see and biopsy other PET avid lesions. Now, talking about the histiocytic sarcoma, the reason I added this after RDD because there is some phenotypic overlap of histiocytic sarcoma to Rosay-Dorfman disease. Now, you can see that this is part of malignant histiocytosis. Again, the sarcoma name could be misleading, but this is part of the hematopoietic system. So this is characterized by, similar to LCS and other interdigitating dendritic cell sarcomas and indeterminate cell sarcomas, characterized by this overtly malignant morphology with marked nuclear pleomorphism with this multinucleation. But the key is immunophenotyping here. These are positive for macrophage markers, CD68, as well as for CD163 and CD14. uniformly positive for cyclin D1, just similar to other histiocytic neoplasms we discussed. Interestingly, this case, it was positive for S100. Now you can see a nice cell that's showing emperipolysis similar to Rosay-Dorfman disease, and these cells were also uniformly positive for OCT2. Now, comparing the S100 plus OCT2, this simulates a Rosay-Dorfman disease phenotype, except that this case is not Rosay-Dorfman disease because the morphology is overtly pleomorphic for a diagnosis of RDD. Theoretically, one could say this represents a malignant form of Rosay-Dorfman disease, except that that is just not a distinct entity. Now, histiocytic sarcoma can have a wide range of phenotypic spectrum. For the purpose of this webinar, I will not go into the details of that. That could be a separate talk in itself for another day. But overall, this cases, and similar to other histiocytic neoplasms, also harbor the MAP kinase pathway mutations, tend to have poor prognosis, but we still have more data emerging in this area as to what is the long-term clinical outcomes in these entities. Now, talking about mixed histiocytosis, the concept of mixed histiocytosis is that there could be at least two or more histiocytic neoplasm that coexist together. But what we know so far in this disease group, histiocytic neoplasm is rare by itself. Mixed histiocytosis is rarest of the rare. So what has been described in the literature so far, LCH can coexist with ECD driven by a common driver mutation, the BRAF V600E. ECD can coexist with Rosay-Dorfman disease, and that is a common driver being MAP2K1, the PI3K AKT pathway mutations. Now, Rosay-Dorfman disease can coexist with LCH, again, the driver being a BRAF V600E again. So these histiocytic neoplasm can manifest as two different sites, or they can manifest at the same sites with two different morphologies. So it's basically the diagnosis is based on an immunophenotypic profile, and also if there is an overlap of ECD, the diagnosis is going to be based on correlation with clinical and radiological findings in addition to histopathologic features. Now, coming to case presentations. So far, we have had an overview of histiocytic neoplasm. Now, let's go apply to each of the three cases that will be presented now. Case number one, this is a 68-year-old man with 4-year history of polyuria polydipsia, diagnosed with diabetes insipidus. The MRI of the brain showed thickening of the pituitary stalk, and symptoms of both diplopia and cranial nerve 6 palsy was present. Patient also had a vague abdominal pain, and when imaging study was performed, it revealed lytic lesion as well as multiple lytic and sclerotic bone lesions. And he has had biopsies over a duration of 3 years, and all of the biopsies were called as chronic inflammation, given this mixed inflammatory infiltrate composed of histiocytes that are foamy and bland appearing, lymphocytic infiltrates, and also some plasma cells in the background, and some giant cells here. So overall, chronic inflammation. But what didn't make sense in this case was the presence of lytic and sclerotic lesions. Chronic inflammation should not give you a sclerotic and lytic lesion that has been persistent over a duration of 3 to 4 years. So let's review the morphology again. Now, again, on higher power, this was very focal on this biopsy. You can see this groove cells here, again, coffee bean-like cells. And this area, like rare few eosinophils were also admixed in the inflammatory background, and some giant cells were present here as well. So with this, the question was, is this Langan cell histiocytosis, and which is usually can present as lytic lesions when it involves the bone. So on doing further immunophenotyping, CD1A and S100 was done, and it showed these clusters of cells. Now, in chronic inflammatory conditions, you can get rare, singly distributed reactive Langerhans cell or dendritic cells, but they shouldn't form clusters like this. Whenever you see Langerhans cells or CD1A positive dendritic cells forming clusters, you're more inclining towards a neoplastic process rather than a reactive process. So additional panel of immunostains were performed. On deeper sections, the lesions was enlarging, and you could see this neatly staining for Langerhans and as well as cyclin D1. BRAF E600 was performed, but by immunostain was negative. Overall, with the immunophenotypic features and the morphologic features, it was diagnostic of Langan cell histiocytosis. Next generation sequencing was pursued. I typically do NGS in all my cases of histiocytosis to identify the driver mutations. So in this case, interestingly, it had a TP53 mutation as well as a P10 mutation. Now, P10 is a part of the PI3K AKT pathway. The P10 is a tumor suppressor gene. So this mutation results in loss of function of P10 gene, and loss of function of P10 results in upregulation of AKT, and that AKT propagates mTOR for tumor proliferation and progression. Now, this upregulation of AKT can be sometimes identified, I would say most times can be identified by immunohistochemistry for phosphorylated AKT. Again, our experience is still evolving this area of using PAKT as surrogate for PI3K AKT pathway activation. But in this case, it nicely stained this lesional Langan cells, suggesting a PI3AKT pathway activation, which correlates with this P10 loss of function mutation. The patient is currently on cladribine treatment and with the possible consideration of mTOR in future. Now going to case number 2. This is a patient in mid-50s who presented with bilateral proptosis, eye irritation, and ophthalmoplegia. Steroids were initiated, but the patient could not be tapered as she had progressive or worsening on symptoms when taper was attempted. An orbital MRI was performed, which showed an extensive bilateral retroorbital lesions. Now compare this to the MRI of the orbit I showed before of an IgG4 related disease. So biopsy of this orbital soft tissue was performed, and the soft tissue infiltrative masses were performed that showed a diffuse proliferation of this foamy histiocytes. The thought was, could this still be IgG4 disease? And IgG4 disease was ruled out by negative staining for IgG4, highlighting only rare plasma cells that didn't qualify for this disease. Lymphoma was ruled out, just like mostly foamy histiocytes, and there was no proliferation, increased proliferation of B cells. Given the foamy histiocytic infiltrate, consideration was given to if this could be infectious etiology. So special stains for GMS and fungi was negative, but as well as clinically, the patient did not have any other infectious related symptoms. So initial working diagnosis was xanthogranuloma. However, the patient had persistent symptoms, had multiple lines of treatment, including mycophenolate mofetil as well as bilateral orbital radiation, but continued to have transient vision improvement, but after some time continued to progress. And that point in time, a whole body PET CT was done, and this was at least 5 months from the initial presentation and initial diagnosis of xanthogranuloma. That PET CT showed, in addition to the bilateral intraconal orbital masses, it also revealed this perinephric bilateral kidney soft tissue infiltration, also known as the hairy kidney, bilateral osteosclerotic lesions as indicated by this PET avidity here, and also a cardiac MRI was performed, which revealed right atrial soft tissue mass. All of this put together were highly suspicious for histiocytic neoplasm by radiology findings. So this case was re-reviewed on the histopathology, and a panel of immunostains were performed, and all of these foamy histiocytes were uniformly positive for factor 13A, cyclin D1, as well as BRAF V600E, which was also confirmed by next generation sequencing for BRAF V600E mutation. Overall, this was diagnostic of Adam Chester disease. Now, the patient was treated with vemurafenib and a MEK inhibitor in combination. You can see a remarkable radiologic response, seeing this resolution of this bilateral orbital lesions, as well as the perinephric PET avid lesions and resolution of this bony lesions. This was quite a remarkable case. Now, coming to case number 3, a young man in the early 30s presented with progressive bilateral diplopia, and that has been going on for 2 years. The patient was physically doing well, except for this vision changes on and off. MRI brain was performed, and it showed a 2.8 centimeter avidly enhancing cavernous sinus lesion. On MRI T2, it was hypo-intense. The lesion was intricately encasing the right internal carotid artery. Now, the imaging findings were suggestive of meningioma unless proven otherwise. So the initial consideration was radiation. However, the T2 hypointensity is quite unusual for meningiomas, as they tend to be iso-intense on imaging studies. So a tumor board consensus was to biopsy this lesion. And as you can see here, you just get this fragments of this tissue because of its intricate nature to the right internal carotid artery. You couldn't get a larger amount of sampling. But with this amount of tissue, what we could say, this was not diagnostic of meningioma. And by morphology as well as by immunostains for somatostatin receptor and EMA. All we could say it was just like a mixed inflammatory infiltrate composed of lymphocytes, plasma cells, some histiocytes in the background. Now, other neural tumors were considered given the location in the cavernous sinus lesion, and it was mimicking meningioma. A CD163 and S100 was performed just to highlight the background inflammatory stroma, and S100 to bring out if there is any other neural tumors that is hiding in there. It was not diagnostic for any other differentials such as malignant peripheral nerve sheath tumor, neurofibroma, a schwannoma, or a paraganglioma. It was not diagnostic of lymphoma. It was a mixed proportion of T and B cells. Pictures are not shown here. So overall, the initial working diagnosis was it's being a descriptive one, mixed lymphocytic and histiocytic infiltrate negative for meningioma. But let's review this area of S100 back. Something it was not really correlating with why S100 was positive in this lesion when there is just lymphocytes and histiocytes in the background that is part of an inflammatory stroma. Going back to the morphology again. So this patient had, by imaging studies, suggestive of meningioma, and I have this scattered S100 staining present. So in reviewing the morphology, what caught my eye was this nucleus of these cells. It's a round to oval nuclei with small distinct nucleoli. Now one could say this is emperipolesis when we are just like saying this nucleus engulfing this lymphocytes here. So I was suspicious for Rosai-Dorfman disease, given the fact that RDD is notorious to mimic meningioma. So compare this with Rosai-Dorfman disease, an actual case of Rosai-Dorfman disease, the morphology is sort of quite similar. Now going into the immunohistochemistry panel, so focusing on the areas that were staining for S100, yes, there are strong nuclear staining, but it's not precisely staining like Rosai-Dorfman disease were, like compared to the other case of classic RDD. So additional panel of immunostains were performed. Cyclin D1 now uniformly expressed. Like I said, usually you don't see this pattern pattern in reactive histiocytic proliferations, but this pattern of staining strong nuclear expression, weak cytoplasmic blush, and also some emperipolesis here. I've said emperipolesis is not pathognomic, but I'm just putting things of all of these features together to see if we can get to a diagnosis. So this was suspicious still for Rosai-Dorfman disease, so I added a OCT2. Surprisingly, to my surprise, OCT2 was negative in those cells of interest. Now, this is your lymphocyte in the background that served as an internal control to see the stain actually worked. But unfortunately, given that OCT2 is negative, made me pause for a moment, because OCT2 negativity in RDD is rare, but can happen in the setting of mixed histiocytosis when RDD is present with ECD, for example. But isolated RDD cases being OCT2 negative, it's quite uncommon in my experience. So I added another stain. It was an ALK immunostain, and to my surprise, I was not expecting this to be positive. It was positive in all those cells that were picking up the cyclin D1, as well as those cells that were variably staining for S100. Now the question comes, ALK being positive, we know this is a histiocytic lesion determined by the positive staining for 163. Question is, what do I do next? I have only this fragments of tissue. Now, given that a number of stains were performed on this specimen, had hardly very limited tissue left. Can I do next generation sequencing? What is the next step? So this case was discussed in a histiocytosis working group consensus meeting, and the radiologist said, which gave me the confidence to go ahead with next generation sequencing, the presence of hypointense lesion is more pointing towards a histiocytic neoplasm and not a meningioma. And this radiology impression made me confident to feel that, okay, this is indeed suspicious for histiocytic neoplasm. Subsequently, NGS revealed a KIF5B ALK fusion confirming the diagnosis of ALK-positive histiocytosis. Now, this is a recently recognized distinct entity in the WHO, which I'll be talking about in the next slide. Follow-up of this case, the patient is currently status post radiation therapy. Given the ALK positivity, there is a potential role of ALK inhibitor in future, and they have fairly favorable outcomes. Now, this entity is recently recognized by both International Consensus Classification as well as the World Health Organization 5th edition. And these are characterized by the presence of ALK gene translocation, specifically Ki5b ALK fusion being the most common. They can be single or multisystemic involvement. Neurologic involvement is fairly more common, especially in infants. Immunostaining panel is classically characterized by the cytoplasmic or membranous staining as well, but we need to confirm the cytoplasmic staining relates to the presence of ALK fusion by genetic testing. The favorable outcomes because we have ALK inhibitors that can be treated for targeted therapy. So now coming to the last portion of this presentation, algorithmic approach to a histopathologic workup. So this is my approach. Again, this is not something that's like a standardized way of protocol to work up these neoplasms. This is just my overview of working up these histiocytic disorders. So whenever I see histiocytic infiltrate that is mass forming, either by pathology, clinical, or radiology, there's a suspicion for histiocytic neoplasm. Get it evaluated by hematopathologist. My recommended IHC panel in all my cases, I do 2 macrophage markers, which is CD68 and 163, CD1A and Langan for mostly Langan cell and dendritic cell lineage. Cyclin D1, as I said, is uniformly expressed in a majority of this histiocytic neoplasms. S100 and OCT2 is, as it's because fairly unique to Rosay-Dorfman disease with this OCT2 staining, but can be present in also ALK-positive histiocytosis. Factor 13A, for the reasons I described for Adam-Chester disease being strongly positive, ALK and BRAF V600 just on a case-by-case basis. If I know I'm not going to do NGS, given the limited amount of tissue availability. If there is enough tissue, I don't bother doing ALK and BRAF V600. I just do sequencing once I do this panel. If this is abnormal, let's subclassify this further. And this table is a summary of what we have discussed throughout this presentation so far. Now, all of these histiocytic lesions will be positive for CD68 and cyclin D1. Rarely, ECD can be negative for cyclin D1. Now, those highlighted in green are those ones that are unique to these diseases. I would say unique in a majority of these cases, factor 13A being strongly positive in ECD, CD1A and Langan only exclusively positive in LCH. Rosay-Dorfman disease also being positive for S100 and OCT2. It can, ALK-positive histiocytosis can mimic Rosay-Dorfman disease morphology, just similar to our case 3, but the key is ALK-positive staining and identifying ALK gene fusions. Now, BRAF V600D is useful in ECD and LCH cases by immunostaining. It's positive in 50 to 60%, extremely rare BRAF staining in Rosay-Dorfman disease. And if possible, my recommendation is to consider next generation sequencing to identify this MAPK pathway mutations in all of these cases of histiocytic neoplasms. So we have completed our learning objectives for today. I take this opportunity to thank all the members of our histiocytosis working group. It's been a rewarding experience working with all these members over the years, trying to integrate patient care for timely diagnosis and management. And a very special thanks to my mentor, Dr. Karen Reck. She's my hematopathology mentor and who has trained me in histiocytic neoplasm, and all the practical insights I've gained over the years is something that I've learned from her. And Dr. Ron Go for the opportunity to work with him as research fellow back in 2015. And I've learned a lot in hematology as well as in the realm of histiocytic neoplasms. And just to give you a graphical figure of our multidisciplinary group, we published this experience over 2.5 years. We saw about 40 cases, and there was change in diagnosis and treatment in at least 1/3 of these cases. This really emphasizes the impact a multidisciplinary group can have in timely diagnosis and management of these rare diseases. With that, I'd also like to thank my UAB pathology team and as well as my Mayo Clinic. And I conclude my presentation. Thank you all for coming to today's webinar and spending your valuable Saturday time. There's going to be some brief presentation by the Histiocytosis Association and Histiocyte Society, after which I'll be happy to take any question. Thank you once again.
Thank you, Dr. Ashwin, for that wonderfully brilliant presentation. It was so crystal clear. You really made the whole subject so easy, very easy to understand. I think all the 5 diseases which you summarized in last 1 minute, that was brilliant. Superb. Very,
Thank
very
you so much. Thank you.
really, we could easily understand every point nicely. Thank you so much for that brilliant lecture. It was fabulous, fantastic.
Thank you so much.
Let me set the screen again. Next, we have our next guest speaker for the day, that is Dina Fournier. Dr. Dina Fournier is the Executive Director of the Histiocytosis Association, a global nonprofit that is dedicated to addressing the unique needs of patients and families impacted by all histiocytic disorders. She is also a histiocytosis patient herself, having been diagnosed with LCH at the age of 6. The association funds several research projects each year, in addition to providing educational and emotional support for families and patients and raising awareness around the world. It's my privilege to invite her to deliver her lecture. Over to you, Dr. Dina.
Thank you so much. And thank you for the very inspiring talk. I really appreciate also the nod to multidisciplinary team. I think it's so important, and really appreciate each and every one of you for being here. So I'm going to share my screen, and I just have a very short presentation about the Histiocytosis Association. As briefly mentioned, we are a global nonprofit. We're located in Pittman, New Jersey, in the United States. We were founded in 1986 by parents whose daughter was diagnosed with LCH. And our mission is to raise awareness about histiocytic disorders through educational and emotional support, raising awareness and funding research leading to better treatments and cure. So at the bottom, you'll see some of the pillars. We have research, clinical trials, and registries that we support. We also have an annual research program where investigators from around the world are eligible to apply to receive seed grant funding for projects into all histiocytic disorders. We have educational resources, including a physician directory and a variety of other resources. We have emotional support through virtual opportunities such as peer chats, and we do a variety of different outreach programs and events. And then our main focus too is to share results that we learn with these experiences with the community to expand their knowledge and awareness. So some examples of some of the opportunities that you as clinicians and investigators, and also the patients that you have that you're treating can take advantage of include up-to-date information on all histiocytic disorders as reviewed by the Histiocyte Society and our scientific committee every time we make updates. As I mentioned, our annual research grant program. We have support for global research initiatives. So if there are projects that you are working on, we're happy to share those out with all of the individuals who we have contact with. That includes patients, families, and investigators from around the world. We have a whole resource database of videos and webinars that you can access that touch on all histiocytic disorders. A physician directory, so patients can search for a physician in their area. It is global. If you are not on the directory, I would encourage you to visit our website, and it's a free form, and you can fill that out, and then we'll publish your information. We have a podcast. We offer regional meetings. We have a student scholarship program for students seeking undergraduate in the United States. We have an awareness toolkit, a peer support program, and very soon we'll be offering grief support as well. And in the future, we're hoping to expand these to the top 10 languages spoken around the world and more. So opportunity to grow. If there are patients in your communities that are eager to have support groups, contact us, and we'll be happy to talk more about how we can make things happen in the coming months and years. We also have an ambassador program as a group of special individuals comprised of patients, caregivers, and caregivers of Histio Angels, and it represents all histiocytic disorders, and they are volunteers and expansion of the association team, and they help us more in their local area, but also in big ways around the United States to support families, participate in research, seek out advocacy opportunities, fundraise, and raise awareness. And I just wanted to call attention to the amazing work that they're doing to help us further our mission. I mentioned the educational channels. So for you as medical professionals, the podcast is a great way to hear more about what's going on for patients, families, but also we interview investigators. We have webinars as well. If you are interested in hosting a webinar, or you can take a look and view the webinars and educational video series. And then we also host regional meetings throughout the United States and participate in the Histiocyte Society's annual meeting. If you're interested in learning more, you can sign up for our newsletter. If you go to histio.org, just look for the little envelope icon and you can sign up for our newsletters there. And then I wanted to just touch on some international collaboration with patient and family groups that we have been working on. And in 2021, the Histiocytosis Association, along with the Erdheim-Chester Disease Global Alliance and the Histiocytosis Association of Canada, formed a partnership called CHIPS, the Coalition for Histiocytosis International Patient Support. And this is a formal partnership that we have decided to come together through in order to support family groups and patient advocacy organizations across the globe. Essentially, we know that together we are stronger, and so we are united to help overcome the gaps and challenges that currently exist for histio patients and families. This international collaboration also has expanded to include other countries. At the 38th annual meeting of the Histiocyte Society, international family groups met with the Histiocyte Society board to discuss collaboration for patients worldwide. The countries that you see on the screen were all represented there, and we are trying to make connections with family groups around the world and other countries as well. If there are active advocacy organizations or family groups that you're aware of, we would love to get to know them and be in touch so that we can include them in these projects. And essentially what we're looking to do is to help broaden our ability to support patients around the world. And last, I wanted to mention our partnership and shared progress. So for nearly, well, it's actually almost 40 years now, the Histiocytosis Association has served as partner secretariat for the Histiocyte Society. And our goal is to alleviate the society's leadership of the administrative responsibilities of running a volunteer-based organization. We're incredibly humbled by the opportunity to partner with them. And we do so, like I said, through the role of secretariat. We also help manage the annual scientific and board meetings and build and manage membership database. And I know that Kathy Wisniewski, who is the Secretariat for the Histiocyte Society, will be telling you more about their work. And so I just wanted to say thank you for the opportunity to share more about the association. Encourage you to sign up for the physician directory so patients can find you if you are treating patients, or any of your colleagues, so that patients and families can find you, and encourage you to sign up for our newsletter as well to keep in touch with all the work that we're doing. Thank you for all that you're doing, and we appreciate the time with you.
Thank you so much, Diana, for that wonderful words, and what a great talk. And it was a really eye-opening for all of us. It was a vision to us also. Thank you so much. Let me share the screen again. We have our third speaker, Kathy Wisniewski. Wisniewski has worked with the Histiocytosis Association and the Histiocytic Society since 2008. During that time, she has held many roles in both organizations, but today her primary responsibilities lie in managing the Histiocytosis Association's research grant program, producing the association's podcast entitled Beyond the Diagnosis, and managing the Histiocytic Society, a global group of over 200 physicians and scientists dedicated to researching histiocytosis, finding better treatments, and ultimately a cure. It's my privilege to invite her for her lecture. Ms. Kathy, the screen is yours.
Thank you so much. I really appreciate the opportunity from the Mumbai Hematology Group to be here and talk a little bit about our organizations. So I'm going to share my screen here. Okay. So as mentioned, my name is Kathy Wisniewski, and I have several roles among the association and the society, but my main responsibilities lie in the society work and managing this group, which is a group of about 250 physicians and scientists from around the world that are committed to improving the lives of patients with histiocytic disorders through clinical and laboratory research. Okay, So the Histiocyte Society was formed back in May of 1985 through a historic international workshop that took place in Philadelphia in the United States. And at that meeting, there were only 15 participants, and that meeting was initiated by Dr. Giulio D'Angio from the University of Pennsylvania Hospital. And this historic meeting led to the foundation of the Histiocyte Society. But today, we subsequently have grown to approximately 250 physicians, scientists, and nurses. And this international society has provided a forum for the exchange of information and framework for organized activities of fundamental importance. So the mission of the Histiocyte Society is to advance the knowledge about and improve outcomes for patients with histiocytic disorders through clinical and basic research and education, with a vision to be the world's leaders in understanding histiocytic disorders and improving outcomes. So with all of this amazing work, where is it all taking place? As you can see on this map, we have members all over the world in all different regions, including 2 members from India. These are our goals that we have for the society to improve the state of knowledge of histiocytic disorders and improve the welfare of patients with these disorders, to promote and facilitate and carry out research into the histiocytic disorders, to facilitate and provide a forum for healthcare professionals for effective communication concerning these aims, to promote education and educate physicians, scientists, and other matters related to the histiocytic disorders, and to advise lay organizations in educational and other matters. Now, through extensive research and collaboration, the Histiocyte Society has made numerous significant strides in the fight against histiocytic disorders. We've established scientific standards for the histiocytic disorders that are accepted worldwide, which include a common language of uniform disease classification, standardized diagnostic criteria, and guidelines for patient evaluation and follow-up. And we continue to work hard every day to make even more strides in our mission to advance knowledge and improve outcomes. So as we move into the future toward fulfilling our mission, we would love to have you join us and be a part of this mission and vision. There are a couple of easy ways that you can get involved. This year, we will have an annual meeting taking place in Athens, Greece, and you can see the announcement there from October 22nd through 24th. That will take place in person in Athens and also online virtually, so a couple of options for you there. And you can also choose to become a member. And we just instituted a very exciting new membership level. It's a 50% discount for trainees, residents, and fellows. So we would love to have you join us in either or both of these ways. And you can get more information on all of these things at histiocytesociety.org. Or if you email secretariat@histiocytesociety.org, that will come directly to me, and I'd be happy to answer any questions that you have. And with that, once again, I would just love to say thank you for having us here. And it's been a pleasure to share with you today.
A big thanks to you. Thank you so much for joining with us today. Now we have some Indian colleagues who are going to bother you with all sorts of questions. So I request all our discussions to please put a raise hand sign first so that we can start our discussion. Okay. So, Dr. Jaspita, your question, please.
Excellent lecture, Dr. Ravindran. It is a pleasure listening to you. The question that I have is that, as you said, that you do NGS in most of your cases upfront if you have enough tissue. So have you had a situation where you are strongly suspecting, say, a LCH, the tissue is relatively, or maybe the NGS turns out negative, and then you go back and do the IHC and the BRAF V600E comes out to be strongly positive? Has that happened to you?
Thank you for the question. I think it has happened multiple times. I would say more than the times I've had able to secure tissue for NGS. There are a lot more times where we don't have enough tissue for NGS. So LCH and Rosay-Dorfman disease cases where we can easily get to the diagnosis by immunohistochemistry. So that is the first go. So NGS, it'll be nice if we have it. If we don't, then it's okay, but at least we're able to get to the diagnosis. Now, the problem comes when it's an Erdheim-Chester disease case and we don't have enough tissue for NGS. The BRAF V600E is positive, and knowing the stain is fairly sensitive and specific, and assuming the positive and negative controls are okay, it also depends upon the lab we perform that, then I would rely on a BRAF V600E positive case in a setting of ECD. I would only say ECD if the clinical and radiologic fits. In my report, I would never put a Manchester disease in the diagnostic line. I would say histiocytic neoplasm, BRAF mutated. This would be most compatible with ECD in the appropriate clinical and radiologic context. But yes, ideally, NGS would be great, but tissue is the issue in many biopsies. We do our best we can, but I was surprised that sometimes even with limited tissue, if you have good number of lesional cells, it still works. That was one of my experience in that ALK positive histiocytosis case, especially. So it's okay to attempt and take it from there.
Thank you.
Thank you, Dr. Jasmita, for that question. Dr. Vinayak Chikodi has a question for you, ma'am. What are interdigitating dendritic cells?
So interdigitating dendritic cells are part of the normal immune environment in general. They are usually present in the lymph nodes, sometimes in the skin, sometimes as part of your immune repertoire. They usually the exact role is not really clear. They arise from the conventional dendritic cells. Now, conventional dendritic cells can have CDC1 and CDC2 types. Again, each of these roles is not really clear now. Our knowledge in this area is still evolving, but I would say interdigitating dendritic cell sarcoma is more akin to your physiologic interdigitating dendritic cell in terms of its phenotypic expression. But there could exist some lineage plasticity, and which would be more, we will get to know more as we do more studies in this realm. So at this point, the exact function or the neoplastic entity and outcomes is not really clear with the data that we have.
Thank you. Here's another question. Is Hashimoto-Pritzker form of LCH common?
I'm sorry, is Hashimoto's
Hashimoto's
Pritzker. Yeah. I'm not aware of that. It's a precursor of, no, I'm not really aware of that. So I don't know. The answer to that question is, I really don't know. I've not heard of that before in any of my LCH cases.
Okay. One question I have, ma'am. We have many questions, patients who are coming with retroperitoneal fibrosis. There are so many patients who have got, mediastinal fibrosis, retroperitoneal fibrosis. And the first thing what comes in our mind is IgG4 related disease. Now, how common is to get an IgG4 related disease, and how to approach and how to differentiate between these two entities, whether it's IgG4 related disease, or when should we suspect it? This can be histiocytic neoplasm also.
Absolutely. That's a fantastic question, by the way, because I think that's something as a struggle that we often face when we are diagnosing these entities. So IgG4 disease is it actually depends upon, there is a histopathologic criteria, there is also radiologic criteria, but the American College, rheumatology criteria, but the American College of Rheumatology consensus guidelines. In terms of histopathologic findings, when you have a fibrotic lesion, and you see increased plasma cells, IgG4 positive plasma cells and increased. Typically, the number of IgG4 positive plasma cells can vary depending upon the organ involved. There is a good modern pathology paper out there that states the consensus guidelines for diagnosing IgG4 disease based on histopathologic findings pertaining to different organs. Most oftentimes in the hematopoietic realm, when I'm seeing lymph nodes or other extranodal site of tissues, I go with like 80 to 100 IgG4 positive plasma cells, number one. And the ratio IgG4 to IgG always has to be greater than 40%. And there is no limited, there is no you cannot give up on that criteria. Storiform fibrosis and obliterative phlebitis, you don't often tend to see. Sometimes what is really storiform? It looks like a cartwheel on morphology, but it can be a little bit of subjectivity added to it. So storiform and obliterative fibrosis, there are other histopathologic criteria of IgG4 related disease, or they may or may not be present in many instances. Now, it would be nice if we have a good rheumatologist and radiology on board and discuss in a consensus correlating with the histopathology. If you're on histopathology, you're seeing increased IgG4 positive plasma cells that are suggestive of IgG4 related disease. It would come to a consensus meeting with rheumatology and radiology to see what their consensus is before you delve into labeling the patient with IgG4 related disease. That is number one thing. In terms of histiocytosis, again, common things being common, IgG4 is always a differential when you're thinking about retroperitoneal fibrosis, but with histiocytic lesions, it depends upon the radiology extent of involvement as well. And when to think about it, it is Rosé-Dorfman disease can present as isolated retroperitoneal fibrosis, but ECD is very unusual for it to present as isolated retroperitoneal fibrosis. It will have other radiology manifestations. So your PET CT findings will be a clue to see if there is a histiocytic neoplasm or not in terms of ECD diagnosis when you're working up. In terms of RTD, only way you can rule it out if you don't see the morphology too, and we see a lot of fibrosis, a lot of dense lymphoplasmacytic infiltrates, it wouldn't hurt to add a CD68 or 163 plus S100. I like to do OC2 because it's a nuclear stain and it brings up the histiocytes very distinctly, and that could be done. And I had a recent case of a perinephric mass that was called as reactive lymphoplasmacytic infiltrate, but turned out to be Rosé-Dorfman disease, and IgG4 was high on the differential. So RDD, yes, of course, in the differential. And remember that Rosé-Dorfman can also be associated with increased IgG4 positive plasma cells. So that doesn't mean the patient have IgG4 related disease. It is a combination of histopathologic criteria, rheumatologic consensus, as well as radiologic findings that have been described based on the clinical guidelines.
One more question I have. Thank you so much for that really eye-opening thing. Another one question I had, that you mentioned about the rheumatological condition. Patient can come to rheumatologist with a bony pain, and you can have this osteosclerotic bony lesions.
Yes.
So any other marker where you can suspect that this can be, histiocytic neoplasm or something like that here? Any blood marker
bony, absolutely,
can do as a clinical parameter?
So, again, it's a very good practical question. All these I face in my everyday practice right now, these challenges. See, osteosclerotic lesion, yes, of course, they can have a plethora of other reactive conditions. Sometimes, myeloma can present like that. Other metastatic lesions can present like that. But your bilateral bony osteosclerosis and radiologic findings of this around this knee bones, that is lower part of the femurs, upper part of the tibia, should actually lead you to excluding a diagnosis of Erdheim-Chester disease. And that is only possible by doing a whole body PET CT and see if there is any other PET avid lesions in non-bony sites, specifically perinephric stranding or cardiovascular involvement, even like the brain parenchymal lesions. So ECD is not just going to be stopped with your bony lesions. It will have like other manifestation, especially when it's presenting at a systemic level. But apart from that, just an isolated bony osteosclerotic lesion, it has to be a radiology and rheumatology consensus. Again, this is where the multidisciplinary approach plays a role, because radiologic differential diagnosis can go a very long way in excluding or including a diagnosis of histiocytic neoplasms. Stating about that, I had a case of bony osteosclerosis. It was initially thought of ECD, but the sclerotic pattern radiologically was not consistent with ECD. Then the patient got diagnosed with osteopoikilosis. That was a case of osteopoikilosis mimicking Erdheim-Chester disease. So this is not really unheard of, the mimics of ECD. But that again, it's a consensus group, pathology, radiology, and clinical, and that is the key to get this prompt diagnosis.
Thank you so much. It's a tough one. Dr. Jasmita, your question, please.
Thank you. So I actually have a couple of questions, simple as well as maybe some which are tricky for me. So what is the clone of CD68 that you usually use?
So I like to use PGM1. PGM1 is slightly more specific than KP1 clone, but sometimes, I use KP1. I'm more a fan of CD163 than CD68. Yes, there are entities that can be negative for CD163, but again, there are approximately, there's a minor subset only in my experience. So I prefer CD163 or CD68. But yes, PGM1 is more specific than KP1 clone.
Can I go ahead with the second question now?
Yes, ma'am. Sure.
Okay, thank you. So for your NGS panel that you talked about, how many genes, and do you do an RNA-seq as well as a DNA-seq, because you're looking at ALK fusions as well?
Yeah, a fantastic question, by the way. I think it's really important to bring up this question for practical learning for everyone. Yes, the one NGS that I have in-house, currently it's a limited panel. It's a 50 gene panel, but it covers the most common MAP kinase pathway mutations, especially KRAS, NRAS, MAP2K1, as well as BRAF E600E, and some of the PI3AKT pathway mutations, specifically the PTAN mutations. Secondly, yes, we do have ALK fusions as part of our NGS panel. In my current practice, yes. In general, it's necessary. It will be good if we can do a comprehensive genetic panel. We are in the process of developing it in-house in our practice here. So a comprehensive gene would be like, anything from 300 to 500. The main thing is like you want to make sure that panel includes your MAP kinase pathway mutations, so including the ones most common that I mentioned. There are some mutations in the MAP kinase pathway which may not be included in my in-house panel. In those cases, I would just do a comprehensive NGS by sending out to an external facility. And yes, I always want to do ALK fusions, especially when I'm dealing with given the evolving knowledge with ALK histiocytosis. If I don't have enough tissue for going into NGS, then I do ALK immunostain. But if I have enough tissue, I make sure the NGS panel has ALK fusions, because ALK positive histiocytosis can mimic ECD, can also mimic like LCH, can even mimic rosacea disease, with the exception that ALK positive histiocytosis is negative for CD1A and Langan, but there are other immunophenotypic overlap with other histiocytic neoplasms.
And what is the depth that you usually target when you're performing this NGS?
So it's usually a targeted NGS. I think it's at least minimum of 30 reads depth, at least. But if you're doing deep throughput sequencing, which is not really available on a clinical basis as of now, but a 30 read should be enough to get what you need for your cases.
Okay, thank you.
Thank you, Dr. Jasmita ma'am, for that question. Dr. Shashi Bansal, your question?
Hi, it's a very fantastic lecture. I just want to know some practical things which I encounter in my practice. Is there any association or spectrum of histolytic lesion association with the acute leukemia? Because we get some marrow which has abundant exuberant proliferation of histocyte in the post-chemo marrow. So what should be the approach for that?
Thank you for the question again. Another excellent question. Acute leukemia, I haven't really encountered a case of histiocytic neoplasm in the setting of acute leukemia as of yet. But in terms of like ECD and LCS, they can be associated with myeloid neoplasm. ECD especially has an increased association with chronic myelomonocytic leukemia, CMMLs. Now, CMMLs, when they progress to acute leukemia and the patient can have ECD concurrently, that can happen. But I have seen ECD in the setting of chronic myeloid neoplasm being more associated. I'm yet to see a case that can be associated with acute leukemias. On the other hand, in the setting of malignant histiocytosis spectrum, yes, I've seen an association of acute leukemia early in a patient presenting at an elderly age, but he had a history of acute leukemia at an early age and developed malignant histiocytosis, that is histiocytic sarcoma, like 30, 40 years later. We couldn't really find a clonal relationship between the acute leukemia component and the malignant histiocytosis component as of yet. So at this point in time, I do not know if they are, but given the fact that they are associated with chronic myeloid neoplasm, the evolution of chronic myeloid into acute leukemia can actually, we can say there is a common mutational landscape underlying both myeloid neoplasia as well as the histiocytic neoplasm, specifically CD and LCH.
Thank you.
Thank you, Dr. Shashi Bansal. Dr. Jasmita ma'am, do you have another question?
Yes, I think I have the most questions today. Dr. Ravindran, like Dr. Shashi highlighted, I worked at a center where we used to get a lot of bone marrows for LCH patients who were diagnosed on tissue as LCH, but now we get the bone marrow. So usually CD1A positive cells are not really seen in the marrow. So some of these LCH cases would have an isolated CD1A positive cell, but no cytopenias. In contrast, there were other patients who had cytopenias, no 1A positive cells, but extensive hemophagocytosis. So how would you sign out these marrows, the two contexts that I talked about?
So if I'm understanding your question right, you do have CD1A positive cells. You mean they are like clustering cells or rarely?
No clusters, rare cells, no clusters.
Got you. Okay. So rare CD1A positive cells, now the most commonly they're just reactive dendritic cells. If you do Langan, they can be just negative. Another clue, you can always do cyclin D1, but you just have to isolate the cyclin D1 positivity if they're present in CD1A cells or not, because cyclin D1 stains your endothelial cells and often can mess up our interpretations per se. They are just reactive dendritic cells. I would not bother about putting much weight on those reactive dendritic cells. Now, I've seen those in setting of Hodgkin lymphomas and other cytopenias. If I ever have to do the CD1A stain, I just say rare CD1A positive cells, most suggestive of reactive dendritic cells, and no diagnostic features of histiocytic neoplasm seen.
So the contrasting situation is when you have a patient of Langan cell histiocytosis, multisystemic disease, you have maybe bi or pancytopenia, and the bone marrow shows hemophagocytosis. Now, typically, either we can call this hemophagocytosis associated with LCH, or maybe this hemophagocytosis actually says that the marrow has an involvement by LCH at some other site, even though we're not able to pick up the CD1A and Langan positive cells in the tissue that we've got.
So hemophagocytosis, yes, it can be associated with infections, it can be associated with malignancies, but say if a patient has LCH and the marrow shows hemophagocytosis, but if marrow doesn't show LCH, again, the first thing is going to be no diagnostic features of LCH is seen. Yes, I see hemophago, but of course we need to do a panel of stains to make sure they are not present there. Hemophagocytosis in this case is likely secondary to the underlying malignancy, and that is not uncommon to see, not just in histiocytosis. Most commonly you see that in other acute leukemias or other malignancies as well. Now, I would just say, yes, hemophagocytosis present in my diagnostic line in the bone marrow report, and say no diagnostic features of LCH. And in the comment, I would say this is likely secondary to the underlying associated malignancy, and there is no features that is present as supported by the negative immunostaining for Langan cell histiocytosis.
So in your practice, have you come across any familial cases of LCH? Because I remember reading a report that it is more common in the Hispanic community and associated with maybe the mutation in the SMAD6 protein.
That's an excellent question. No, not yet. I've not come across a case of familial LCH, but my practice is mostly adult-oriented practice. I don't do pediatric cases as much. So that is also like a bias towards the adult population here. So I have not seen, not in my current practice and not from my prior training years, as you know, I trained in an adult specialty hospital as well as I'm practicing in like adult-oriented setting. So yes, I think it might be more, you may see that in a pediatric setting, but not yet.
Thank you, Dr.
Thank
Jasmine,
you.
for that wonderful question. Anybody has any other question? Because I finished. Dr. Vinayak Chikori has just mentioned regarding this Hashimoto Pritzker form of LCH, that it has been mentioned in that Ackerman surgical pathology book. That is a self-healing form of LCH.
I'm sorry, what is it called?
It's a self-healing form of LCH.
Okay.
Yeah,
well, so I don't know about that entity per se, but I can talk in terms of self-healing form of LCH. Historically, pulmonary LCH has been thought to be representing a reactive proliferation of LCH given its association with smoking. And once you stop smoking, the pulmonary LCH lesions resolve. So it was considered to be that. But now there is evidence that proving that pulmonary LCH also harbors MAP kinase pathway mutation in over 80% of the cases, and are truly clonal in nature. Although they might be self-resolving after the smoking cessation, that biology is still not clear, is still in the works, but all of these LCH cases are clonal in nature. So it'd be interesting to sequence those cases. Although they may be self-resolving, it also relates to the biology of these LCH progression, depending upon where the hit occurs, either from the stem cells lineage or towards the latter part of differentiation. That matters in the setting of resolving histiocytic lesions. And in terms of LCH also, it would be nice to sequence them for NGS and prove that declonality, although they may be self-resolving.
Thank you. We know that there are so many cases of LCH we do get basically. So before starting any treatment, should we go for NGS in all the cases for newly diagnosed LCH?
So that is a conversation that I always have with my hematology colleagues, and I will ask them. It's like some cases of LCH. Say if I know the beta V600 is not positive by IHC, And if the tissue is limited, my first question is to the hematologist, do you want me to pursue next generation sequencing? Is it going to change your management? That is number one. Number two, it is like, if they say, yes, they need it, I still go ahead and pursue NGS. If they say, no, it's not going to change their management because sometimes they can treat empirically with different drugs that has been available, then, then we don't need to go that extra step forward to do NGS. But in my practice with my hematology colleagues and the way we have developed, we try to sequence all our histiocytic neoplasm cases. So I would take it on a case by case basis. And also this applies to, for example, I think Rosé-Dorfman disease would be an excellent example to give. If it's just an isolated nodal involvement and a classic case of RDD, patient has no symptoms and can be observed, and NGS may not be necessary at that point in time. But the patient has RDD. I had a recent patient who had like multiple aggressive lytic lesions, turned out to be Rosé-Dorfman disease. In this case, absolutely sequencing is necessary because the patient can get treated because it's behaving aggressively in clinically is behaving very aggressively. So I would go from patient by patient in terms of assessing whether NGS is needed or not. In a case suspicious of ECD, absolutely yes, for all cases, I will send for NGS because without that, we cannot get the diagnosis right.
Thank you so much. That was a real learning point to all of us. Thank you so much. Anybody has any other question for ma'am? Well, so that brings about to the end of this.
I think Dr. Jasmeeta has a question.
Yes, he has. Oh,
Yeah.
Yes, ma'am. Please go ahead.
So I happen to remember that you were talking about interdigitating cell sarcoma and that it sort of is S100 positive and you would think of a differential of melanocytic tumors.
Yeah.
So what is the typical panel that you would do in that case, and what takes you towards IDCS over a melanocytic?
So that is IDCS being a part of malignant histiocytosis. That can be a whole separate 1 hour talk for me to talk about the phenotypic spectrum. So it would be like too less of a time to talk about the phenotypic spectrum per se. But yes, in terms of when I'm working up those diseases, it's just similar to any other histiocytic neoplasm that I do a panel of macrophage markers, either CD68 plus CD163. I do like CD14. The Langan cell dendritic cell markers include CD1A, Langerin, as well as CD11C. I do BRAF E600D as well. And in addition to that, I do S100 and OCT2 and factor 13A. This is my standard panel for all of them. But for malignant histiocytosis, I do CD14, CD11C, as well as lysozyme. And that has some lineage plasticity, lineage differentiation clues, or the lineage plasticity of these malignant histiocytosis. Some of them can like express certain amount of markers, some of them can express a different set of markers. So yeah, in those settings, in addition to the panels I described, I add some additional things. But yes, that could be a talk by itself. So, please invite me. I can give a talk sometime down the road on malignant histiocytosis phenotypic spectrum. But it's very rare. I've probably seen only one case. That's because of my interest in these diseases. But the most important thing to remember is that they can mimic melanoma. So we shouldn't bounce to a diagnosis of melanoma without adding a CD68 or thinking about the histiocytic lineage tumors, as it has completely different set of treatment protocols and impacts patients' management.
Actually, my worry was that more often these cases may be misdiagnosed as melanoma and they don't end up on your table, for example, because they're not really referred.
Absolutely, I completely hear you. That is one of the things to bring up those entities here for today's talk, is to create awareness that, the word sarcoma can be very misleading. And oftentimes this paper, even Rosé-Dorfman disease, sometimes these patients don't go to hematology. So what I do when I'm looking at these cases, and what I recommend to my colleagues also as well, is that when I see this group of diseases, I know this is histiocytosis, I know this comes under the hematopoietic realm, I put it in the comment in my report, suggest hematology consult. Per this classification, this is considered under the spectrum of histiocytic dendritic cell neoplasms. And if I know a particular hematologist, I even suggest their name right up front in my report, because this patient comes from different communities all over here as well. And oftentimes the internist needs to know who to channelize these patients to, not to soft tissue sarcoma oncologists, but rather to hematology and oncology, hematologists specifically for a precise management. So that is important to know. Hence, it's up to us as pathologists to see if we can guide the patients rightly to towards the right direction, so they can get treated appropriately.
And the acute leukemia that you described that progressed to malignant histiocytosis, was that a acute lymphoblastic leukemia by any chance?
That's a great question. I do not know because we couldn't get those records from young age. It was just a history of acute leukemia. So we ended up doing both T cell gene arrangements and B cell gene arrangements on the malignant histiocytosis component. Both of them came back negative. So the suggestion is like it's probably a de novo malignant histiocytosis. I'm putting to a broad term of histiocytic sarcoma and other lesions I described. But yes, theoretically it was a de novo histiocytosis rather than a progression from a prior acute leukemia. But in order to prove if something is arising from acute leukemia, you need to demonstrate clonality in your malignant histiocytosis component that relates to another malignancy, whether it's lymphoma, whether it is myeloid. Usually they have like shared clonal mutations, and you can sequence them separately to prove that shared clonality.
I've actually come across one case of malignant histiocytosis post a diagnosis of ALL, and on extensive literature review, I did come across around 20 odd cases that had progressed to MH. And this was obviously after a considerable amount of time, about 3 to 5 years of the ALL diagnosis. I don't remember coming across the clonality report in any one of them because maybe the disease was per se so rare that the workup wasn't done in that scenario.
You can always, go back if you have that ALL tissue, you can do the genetic mutation profiling. Now that, we know that ALL has kind of like set of mutations that can be associated with that disease, and as well as do the same mutation, same panel in the malignant histiocytosis component, and can see if they are shared. Some mutations, any mutation that could be, and that could have been the driver to set up the malignant histiocytosis differentiation at a later part from the prior existing ALL. But yes, whether it's de novo or transdifferentiated, the main way to distinguish is to demonstrate the underlying clonal genetic landscape between the two different entities, and if it's occurring in the same patient.
Thank you so much, Dr. Jasmita ma'am, for that question. So if no one has any other question, that brings about the end of this webinar. I may say, Dr. Aishwarya, you were so fabulous, so fantastic. What a flow you had in your talk. And the last minute of summarizing how to differentiate with all these 4 entities was just wonderful, excellent, and fantastic. Thank you for joining. Really a big hands to you, big salute to you for what a flow, wonderful lecture, and what a discussion. Thanks. Thank you so much. And you really made the whole complex topic so easy that everybody of us could understand.
Thank you, Dr. Ahmed. Thank you very much. Thank you, Mumbai Hematology Group, for the opportunity to present today. I really enjoyed sharing the knowledge that I've acquired from my mentors and from my patients, and trying to, create awareness. And together we all learn. And thank you for that very excellent questions. They are all those questions that I encounter in daily practice. Each case has a challenge by itself. And through each case, we learn more, and we tend to apply more in other cases for a timely diagnosis. So thank you all for your time and for inviting me for this talk today.
And big thanks to Deanna and Kathy to join us.
Thank you. And thank you for the wonderful talk. Really appreciate it.
Thank you so much.
Thanks a lot.
This has been wonderful. Thank you.
Okay.
Thank you, Dr. Ahmed. Thank you,
Bye,
Diana.
everyone.
Thank you, Kathy. Bye.
Thank you.